Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bower, the editor of GP Online. Today on the podcast I'm joined by our deputy editor Nick Bostock, and later on we'll be joined by our senior reporter Kimberley Hackett to talk about the latest news stories affecting general practice. Coming up, we're talking about GPs being employed under the Additional Roles Reimbursement Scheme and looking at what we know about how that's going. We're also talking about how the ARRS more generally has reshaped the workforce and how changes in general practice in recent years, including the ARRS and remote consultations, have impacted on quality. And we're talking about the current problems at the CQC and how this is affecting practices. Our good news story this week is about changes to the GP exam resit policy for GP registrars who are disabled. That's all to come on this episode of Talking General Practice. Just before we get started, if you are a GP doing locum work, we would really appreciate it if you could take the time to fill in our annual GP Online and GP Business locum rates survey, which asks about the rates locums charge for work and other issues that affect locum GPs. Everyone who completes the survey will be entered into a prize draw to win £250 of John Lewis vouchers, and all answers will remain strictly confidential. You can find a link to the survey in the notes for this episode. Thank you in advance for your help with this. First up, let's talk about the GP ARRS jobs. So just as a recap, back in August last year, the government announced that more than 1,000 GP jobs would be created in 2024-25 through an £82 million expansion of the Additional Roles Reimbursement Scheme. That money applied to the second half of the financial year, and we saw final guidance on how the scheme would work published at the end of September, and we reported on the first GPs taking up these roles towards the end of October last year. These jobs are only available to GPs who have qualified in the past 2 years and who have not previously been employed in a substantive GP post in a practice. Nick, the last time we talked about this on the podcast, we were discussing some concerns about how attractive these jobs were to new GPs. Do we know how many GPs have been recruited through the scheme? Are PCNs making use of this money?
We've reported a lot over the past year or so on GPs struggling to find work. We've talked about a GP working as an Uber driver, a registrar applying to work with Tesco, GPs using food banks. And they're really shocking stories at any time, but all the more shocking when we know general practice is under more pressure than ever, delivering more appointments than ever. And the UK's training more GPs than ever before, so the supply lines should be working. But many GP practices can't afford to recruit, which is something we've obviously talked about before on the podcast. The BMA and RCGP have said that thousands of qualified GPs are currently unable to find enough work. So that's the context. And after the general election last summer, Wes Streeting, the Health and Social Care Secretary, spoke about how absurd that was and came up with this plan to put an extra £82 million into creating 1,000 GP jobs through the ARRS. This was intended to pay for GPs to be employed for the second half of the current financial year, so from October 2024 to the end of March 2025. But it hasn't been plain sailing for a number of reasons. The idea of these ARRS GP jobs was first announced in August last year, as you touched on. But detail of how the funding would work wasn't made public until right at the end of September. So it was basically impossible for PCNs to hire anyone by the start of October. And as far as we know, no GP had started an ARRS job until November, just 5 months from the end of the financial year and a month after this scheme was meant to get going. So actually they'd been appointed by the end of October, but in terms of start dates, they didn't come until November, as far as we know. GPs have also been concerned from the start about the fact that these jobs are being funded at PCN level rather than through funding for individual practices, and about the level of funding on offer being too low to be attractive. And some GPs we've spoken to say that without practices agreeing to top up the money, there's just no way they're going to be able to recruit. So in terms of facts and figures, the government and NHS England have both refused to say at this stage how much of that £82 million has been claimed by PCNs towards recruiting GPs, or to confirm how many GPs have actually taken up ARRS jobs. So there's no official sort of running total. But I spoke to a GP this week about a conference he went to in December, and at that event, a senior member of the RCGP said they'd been told that just 300 posts had been filled at that stage. The RCGP hasn't commented further on that, and the government wouldn't confirm that figure when we asked. But that's one bit of evidence that points to a slow start. There are some figures coming out shortly about the primary care workforce that might shed a bit more light on some of this. There was another clue last week suggesting that ARRS GP jobs aren't doing brilliantly, which was that NHS England sent out this letter to remind PCNs about it and to encourage them to try to recruit GPs through this way. So from what we know, it looks like that target of creating 1,000 GP jobs in the current financial year by the end of March is actually a long way off as things stand.
That letter NHS England put out last week encouraging PCNs to make use of the money that's available, it really does suggest things aren't going too well. What did that letter actually say?
So that letter from NHS England said that many PCNs have begun using the money for ARRS GP jobs, but it also mentions PCNs that have not yet claimed reimbursement for any GPs hired through the scheme. So it's very clear that in some areas it hasn't taken off at all, or at least it hasn't taken off just yet. NHS England has given PCNs that are yet to claim any ARRS GP funding until the end of January to spell out what their recruitment plans are. So it'd be interesting to see if some turn around and say, this just doesn't work for us and we're not going to do it, or whether this is the spur that PCNs need. If they haven't got going yet, then now perhaps they will. One thing the letter mentions is that NHS England had heard from GPs that a lack of clarity over whether the money for GP jobs created through ARRS was going to continue beyond the end of the current financial year was a sort of barrier to recruitment. But this all points to one of the things we talked about on the last news podcast, and that's about the government's decision to announce a funding package for general practice for next year earlier than usual. And that was all about trying to provide that clarity.
You've been talking to GPs about these ARRS jobs. What have they been telling you about how people feel about these posts and how attractive they are?
Maybe the biggest concern we've heard from GPs is around funding. The funding available for a full-time ARRS GP salary through the scheme works out at just over £8,000 a session. The BMA's called that derisory, and one GP I spoke to this week said that that's just nowhere near the going rate, which he said was closer to £10,500 or even up to £12,000 a session. So I think particularly in parts of the country where the shortage of GP jobs is perhaps less acute, London maybe, attracting doctors with that sort of pay is a real struggle. And what that means is that to make use of the money, practices often need to top it up. I spoke to a GP in the Midlands who said practices in his PCN were doing that. They'd been given a share of the money available at PCN level to create part-time roles, and then they'd each topped up the funding to be able to offer pay at a competitive rate. But clearly, GP practice finances are tight, and not all practices are going to be able to just find the money to top up the salary to a level that's going to attract a GP into the role. A GP I spoke to in London said that in his area there was a conversation going on within the PCN, but that not all practices in the PCN were interested in topping up pay to make this work. And this issue of money comes on top of other concerns, the fact that the jobs are only open to newly qualified GPs, for example. One GP I spoke to said he thought jobs at PCN level, and especially ones that might be part-time or spread across more than one location, might actually be better suited to GPs with experience. It seems like there's reluctance from the organisations meant to do the recruiting on the one hand, but also reluctance from GPs who are expected to come forward and apply for the jobs. I was told last week about PCNs having to reissue adverts for ARRS posts because there's just been a lack of interest the first time around.
That's something that certainly came through at the England LMC's conference. There was a couple of GP registrars who got up and spoke at debates and said that they felt that those jobs were just not very attractive to them as GPs who are due to qualify in the coming months. You mentioned there about the early announcement of the funding for the GP contract this year it was kind of a way to reassure people that this money was going to continue after March. That sort of suggests that the government is a little bit worried it's not going to hit this target. I mean, they've been very public about saying they were going to recruit 1,000 new GPs fairly soon after they were elected. Do you think they are worried that that target's going to be missed?
Yes, I think the government is definitely very worried about that. In response to questions about problems with general practice, the government always cites the £82 million investment in creating 1,000 GP jobs through the ARRS as one of the main things it's doing to kind of tackle the problem. So if those jobs don't materialise, it's going to be a real issue and a sign that this undoubtedly well-intentioned plan to boost the GP workforce hasn't quite landed as it hoped. Perhaps what this comes back to is one of the GPs I spoke to this week said that in drawing up these plans, really this just speaks to the fact that perhaps the government hasn't spoken to general practice, to GPs on the front line enough about how to shape this kind of workforce plan to make sure that it's something that was going to work.
Yeah, definitely. They really wanted something that would be able to be implemented quickly and fix things. But obviously, as we've talked about so much on the podcast before, really the fundamental problem and the reason the jobs crisis is there and the reason that people are struggling to find jobs is because practices do not have enough money in core funding to recruit the GPs they need. And obviously, that perhaps is a bigger issue that needs to be solved. So the government has done this to try and do something relatively quickly. But as you say, it's a very well-intentioned plan, but maybe one that is not going to come to fruition as quickly as they might like. The second thing we're talking about this week also relates to the ARRS. Last week, the Nuffield Trust think tank published a report about the changing mix of professions in the NHS, which have been commissioned by NHS employers. Nick, the headline of the story that you wrote about that report for GP Online last week focused on a pretty major shift in the makeup of the workforce in general practice. The report was about the NHS as a whole, wasn't it? But what did it actually find out about what was going on in general practice?
The report talked about a really stark change in the workforce in general practice in recent years. About a decade ago, the ratio of GPs to other clinical staff working in general practice, so nurses, pharmacists and so on, was about 1-to-1. So one GP for each of those other clinical members of staff. But this report points out that ratio has shifted really dramatically to the point where GPs are now outnumbered by almost 3-to-1. It's actually 1 to 2.6. We've been talking about GP ARRS jobs just now, but those are only something that's been added very recently to this scheme. And one of the key things that GPs have been complaining about when it comes to the ARRS up until last year was that none of the $1.4 billion a year that it provides in funding to recruit staff into general practice could be used to recruit GPs. And that funding has brought in around 35,000 other staff, pharmacists, physios, paramedics and others, but not GPs up until now.
The report highlighted that this change in skill mix is something that's happening in other countries as well. But it said that in England, in particular, England had seemed to have gone further than most of these other countries, and that general practice in particular had seen rapid change, didn't it?
That's right. Skill mix is something other countries' health systems are looking at too. But this report said England has gone faster, and it raises some real concerns around that. The Nuffield Trust said that in the past 5 years, 78% of growth in the workforce in general practice had come through the ARRS. So obviously, again, up until now, that hasn't included GPs at all. And it said that the way money was ring-fenced for non-GPs through the scheme seemed to be distorting local decisions around recruitment and driving this kind of expansion of new roles at the expense of traditional roles in general practice. We reported last year on the National Audit Office warning that the whole NHS workforce plan, this is the NHS workforce plan that the last government put out, was built on substitution of GPs with other health professionals. So actually, it's not just other health professionals as in people who will never be GPs, but it was also about leaning more heavily on GP registrars, so people who are not fully qualified GPs yet. But this report basically seems to expose the scale on which that's already happening. And it says the government and the NHS need to look again at the way that what it calls salary reimbursement initiatives, like the ARRS, can distort the way the NHS workforce evolves. And it says basically that although expanding the balance of professions in the health service is a key part of shaping its future, there's been a tendency just to sort of press ahead with making those changes without enough planning for the impact that those changes can have.
The report highlighted concerns that lots of these new roles have been rolled out before issues around regulation, training, supervision have been properly sort of sorted out. You can see that really clearly now, can't you, in the current situation with physician associates in the NHS. What did the report actually say about this, and what are the implications for the future?
It made the point that exploring skill mix, working out how other roles, new roles, can support more traditional roles in the health service is really important. But it made the point that you can't just lob them into the mix and expect it to work. You need to think about regulation, training and supervision, and then crucially, who's going to provide that training and supervision, and whether the people you want to do the supervising have the capacity to do it. We've talked about the fact that GPs have really struggled with the workload and the increased risk that they carry when they're expected not just to see patients themselves, but also to supervise other staff seeing patients within the GP practice where they work. We've talked about concerns around the lack of clarity about the scope of work physician associates, for example, can take on in general practice, and the controversy that's followed, the guidance from both the BMA and RCGP that's tried to sort of fill that gap. And this report makes all these points. There's been a lot of change very quickly, but again, without the planning apparently needed to make sure it can work.
You've also mentioned that National Audit Office report highlighting concerns about substitution of GPs and the NHS workforce plan. The current government has promised an overhaul of that workforce plan as part of the 10-year plan for the NHS it's currently putting together. And one of the driving factors behind overhauling that workforce plan is a focus on growing the GP workforce. Do we know when this new plan is likely to be published and what's likely to be in it?
The government said that revamped workforce plan will be published this summer. As you said, it's promised that part of the changes are going to involve more GPs. When we wrote about that NAO report last year, one of the points we picked out was that it said the last government's workforce plan would have meant hospital consultants increasing in number about 12 times faster than numbers of GPs over the decade to come, up until about 2035, 36. The government's outline of what it wants from a revised workforce plan highlighted exactly that point. It looked at that particular imbalance, as well as the fact that the share of NHS funding spent on general practice has been going down. So obviously, we're going to have to wait until summer to see exactly how the workforce plan is going to be changed and updated by the current government. But there is a sense that with the current government identifying moving care from hospital into the community as one of its sort of key priorities for the health service, there may well be more of a focus on boosting GP numbers as part of that.
What's interesting, is the shift in the workforce which you're talking about is just one of many significant changes in recent years that have had a really big impact on how general practice operates. Obviously, the other big shift has been this move towards a greater use of remote consultations and the rise of digital technology. And a lot of these things have been introduced with a view to helping practices manage patient demand. There was a really interesting piece of research in this month's edition of the British Journal of General Practice, actually, which looked at how these changes, as well as changes in the wider NHS and social care, for example, around austerity and pressures in secondary care, about how they've all impacted on quality in general practice. And the researchers found that a lot of the measures introduced to help support practices and increase efficiency, including the expansion of additional roles and the greater use of digital triage, they'd actually had unintended consequences that could increase inefficiency and affect quality of care. I mean, there's a lot in that research. You could do a whole podcast on it, to be honest. And a lot of it was really about the impact of remote consultations and digital triage and increased protocolisation. But I think there is some crossover to what we're talking about today in terms of the shift in the workforce. which goes hand in hand with some of those issues. So one example the research highlighted related to digital access and additional roles. It found that digital triage systems, which practices often use to help patients get to the right healthcare professional, that these systems often rely on a lot of protocols and require patients to prioritise one problem at a time. So the upshot is that they potentially needed to see multiple different professionals for each issue, rather than having maybe one or two appointments with a GP, as would have been the case in the past, who could potentially have dealt more efficiently with all of the problems in one go. So that's quite a good example of how changes in the workforce we're talking about today and how that might impact on patients' experience of how care is delivered. That research also highlighted something you mentioned, Nick, was about the stress among GP partners in particular had been exacerbated by what it called a high burden of supervision of other multidisciplinary roles. And that's something we've talked a lot about on the podcast before, isn't it? I mean, as you introduce these new roles, they require a lot of supervision. It's GPs who do that, and then if they're supervising staff, then they're not seeing patients during that time. Anyway, as I said, there's quite a lot in that research, so we'll put a link to that in the notes for this episode if anyone's interested. I mean, one of the other things that's perhaps worth mentioning on this, Nick, is that you wrote another story that's sort of related to this about physician associates recently, and about the BMA saying that practices were entitled to make PAs redundant if they felt they could no longer employ them following the publication of that BMA and RCGP guidance on scope of practice that you mentioned earlier. I mean, are PAs being made redundant by primary care networks in light of that guidance? What do we know about that?
The guidance you mentioned, and this is separate pieces of guidance from the BMA and RCGP that came out last year, tried to provide a bit more clarity for general practice about the role that physician associates can play. And that guidance set really strict limitations on the role PAs can fill in general practice and in terms of the level of supervision that they need. And it set out a very different vision compared with what NHS England seemed to have in mind when it first sort of set out plans to bring PAs into the general practice workforce through the ARRS. For example, NHS England's original guidance said PAs should see undifferentiated patients, but the BMA and RCGP guidance said that shouldn't be happening. An organisation called United Medical Associate Professionals, which represents associate staff, including PAs, said at the end of last year that the BMA and RCGP guidance had led to more than 200 PA redundancies in general practice. Basically, it suggested that the guidance had restricted what these staff could do so much that practices no longer felt they could use them, and so were letting them go. UMAPS, this organisation, says it's putting together legal challenges around some of these redundancies. But as you mentioned, the BMA said recently that practices are entitled to follow advice that it and the RCGP have put out around PAs, and it's suggested that this is still the case, even if it leads to practices ultimately deciding that the way that this changes the nature of the job that these people can do, that practices feel perhaps that they need to make redundancies.
One other story I thought it was worth talking about this week involves the CQC, the Care Quality Commission, and this comes off the back of an appearance at the House of Commons Health and Social Care Committee by new CQC Chief Executive Sir Julian Hartley and the regulator's chair Ian Dilks. During that session, Sir Julian revealed that 500 assessments of health or social care providers were currently stuck in the CQC's IT system. Nick, you've been trying to find out whether this is affecting GP practices. What did the CQC tell you?
The CQC said earlier this week that most of those 500 assessments that are stuck in its system relate to adult social care providers, but not all of them are. So I asked what proportion are for GP practices, but the CQC said it didn't have that information or it couldn't provide it at this stage. So just to be clear about what this means, the CQC aims to complete all reviews within 50 working days. So inspections should become published reviews within that time frame. But the CQC chief executive told MPs that in some cases there were delays going back months. So some providers that have been inspected still have no idea months later what their rating is or what the outcome of the inspection is. And he also said that there's a backlog of 5,000 notifications of major concern. That's a small part of the number of notifications that the CQC gets per year, to be clear about that. But this is cases where providers or members of the public flag a concern, these 5,000 cases have not been responded to within the 10-day target time frame. And again, apparently these cases go back months in some cases.
Do we know how any of this is affecting GP practices? Your story did include some details of a practice that has potentially been affected by this issue, didn't it?
Yeah, so in the case of this particular GP practice, which seems to be caught up in the problem with delayed assessments, it had a CQC inspection in June 2023 and was rated inadequate on the back of that inspection. And the GPs at the practice say they basically moved heaven and earth to try and turn things around in the months after that. And that a year later, the CQC came back for a follow-up inspection. So that was in June 2024. And the practice was hoping that that follow-up inspection would lead to a much improved rating. But 7 months down the line, it still hasn't heard a thing. And one of the partners said on social media that this huge delay is actively damaging the practice. They're struggling to recruit. They've lost out on taking on new services because they're stuck with this inadequate rating, which may well be completely wrong after the improvements that they made.
That's just so disheartening, isn't it? It must be awful in that situation, because I'm sure they've worked incredibly hard to turn things around. But most people I've come across who've been in that situation will have worked really, really hard to make the improvements that the inspectors have told them they needed to make. And it's pretty appalling if they haven't got the results of their follow-up inspection yet. But do we know why these assessments are stuck in the system? What is wrong with the IT system?
The CQC staff who gave evidence to the Health and Social Care Select Committee said they couldn't say exactly what had caused the problems, but they did say that the problems they were having were almost unbelievable. That was the phrase they used. And they said that in some cases, staff start work on a report, put it in the CQC IT system, and then it just seems to get stuck. They said the reports are basically somewhere in the IT system but can't be retrieved. And in some cases, this issue, as we've said, has been going on for months at a time. And they said basically that in some cases, staff have started writing up the report, perhaps realise they need a bit more information, so they save it in the system or something along those lines. But then when they come back to update it, they simply can't access it anymore.
It doesn't really fill you with confidence, does it? I mean, a lot of the problems the CQC seems to be having have come about around the same time as it's been trying to introduce a new approach to regulation. And at the heart of that new approach is supposed to be a greater use of data and IT and analysing data about providers to help the CQC direct then which practices or hospitals or social care providers they deem to be high risk, and then concentrate inspections and resources towards those providers. The idea was basically effectively all providers would almost be kind of constantly monitored in the background through this data analysis that would be going on. You know, obviously something like this IT problem the CQC is having that you're talking about here, Nick, I'm sure that lots of people would be quite worried about that approach given what's going on at the minute. And it doesn't really basically fill you with confidence that those systems are robust enough. But as far ago as July last year, the CQC had to apologise about the rollout of its new regulation system because there were so many problems and technical issues with the new provider portal, for example, that practices and other organisations were supposed to register on. But there's been all sorts of problems with the CQC over the past few years, haven't there? Wes Streeting said the CQC was not fit for purpose shortly after the election, after a government commission report highlighted major failings at the regulator. These included things like, lack of clinical expertise among inspectors, inconsistency in assessments, as well as those problems with IT we've been talking about, and the fact that they're not doing enough inspections. I mean, that seems to be a real problem at the minute. What else did the new CQC chief executive have to say to MPs about some of these problems, and perhaps more importantly, what they're doing to fix them?
We know where GPs stand on this, don't they? I mean, LMCs voted last year to sort of scrap the entire CQC inspection system and said it's fundamentally flawed. As you mentioned, Wes Streeting said at the end of July that he was stunned by the extent of problems at the CQC, and he declared it not fit for purpose. As I say, that's a verdict that GPs would probably have agreed with some time ago. You mentioned the point about not doing enough inspections. The not fit for purpose line from Wes Streeting came from an interim report from a review into the CQC by Penny Dash, who's the chair of an ICB in North London. And when the final report came out last year, part of the CQC's response was to promise to step up the number of inspections it carried out. But at the Select Committee hearing the other day, they kind of revealed just how far behind they've fallen on that front. So Julian Hartley, who's the chief exec of the CQC, said that it carried out 2,500 inspections in the past year. And he said that was significantly less than in any previous year of the CQC's operation. And he talked about ultimately needing to give the CQC's inspection staff the tools they need to do their job, which, suggests that obviously at the moment they don't feel they have that.
I mentioned there that Julian Hartley, he's come into the CQC very, very recently as the new chief executive after all sorts of problems. So he's got a big job on his hand there, hasn't he? There's actually currently a wider review of NHS watchdogs going on at the minute after the back of that CQC report. And that could potentially lead to a big overhaul of how regulation works in future, potentially might mean the end of the CQC. I think many GPs would definitely welcome a big change in the way regulation works, as you mentioned there, Nick. And I guess if the CQC can't get a handle on some of these problems, then we could see some major changes in future. Just before we go, we've got time for our good news story this week, which is about a change in RCGP policy for exam resits for GP registrars who are disabled. And I'm joined now by our senior reporter, Kimberley Hackett, to talk about this because this was one of her stories. Kimberley, we actually talked about this on the podcast a while ago, but can you remind people what the background to this story is?
Yes, so at the end of 2023, the BMA launched a legal challenge against the RCGP over its exam policy. The BMA took this legal step on behalf of a GP registrar who found out she had a neurodiverse cognitive profile after she had already failed the applied knowledge test 3 times. She was allowed reasonable adjustments to account for her neurodiversity in her 4th test, which she narrowly failed, as she did in her 5th attempt, granted exceptionally by the college. The college then rejected a request to void the exam attempts prior to the diagnosis of neurodiversity, arguing that it was duty-bound to uphold these regulations consistently for every trainee. The case ended up in court last August, and the judge ruled that the decision to deny the GP registrar additional attempts to sit the exam was irrational. But the judge found in the college's favour on 4 of the 5 grounds of the BMA's challenge.
Yeah, and so what's happened over the last week or so? What changes have the college made?
So the college has now said that GP registrars who fail their exams and are later diagnosed with a disability will be offered additional attempts and can apply to have previous exam results voided. The college said that this decision was made after a consultation with the GP education and training community, including GP registrars. Following the announcement of the changes, the BMA described it as another win for GP registrars, and the RCGP chair told GP Online that the college is proud to have a diverse and thriving GP registrar community and takes its responsibility to all members seriously and aims to be an inclusive organisation where diversity is respected and encouraged.
Well, that's it for this week. Thanks so much for listening, and thanks to Nick and Kimberley. I'll be back next week where I'm talking to Ruth Rankin, who's the Director of Primary Care at the NHS Confederation, about creating a neighbourhood NHS and what that means for GP practices and primary care networks, including how the GP contract may need to change. So do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice on our website at GPonline.com.